And I'll go ahead and start by introducing myself. I'm Cliff Dupre with the Salud America team here at UT Health San Antonio. Welcome to our final webinar in our 6th webinar series, Let's Address Health Equity Together. Today's webinar is Ladies, Why Should You Get Screened for Cancer? Our moderator is Dr. Amelie Ramirez. Dr. Ramirez is director of Salud America and its home base, the Institute for Health Promotion Research at the University of Texas Health San Antonio. She's got over 30 years of experience directing research on human and organizational communication to reduce chronic disease and other cancer health disparities affecting Latinos. She's also Associate Director of Cancer Outreach and Engagement at the NCI-designated Mays Cancer Center at UT Health San Antonio. I hand it off to you, Dr. Ramirez.
Great. Thank you so much, Cliff. And thank you all for attending our session today. We're really excited to have you here with us. And we just have a tremendous group of panelists. And today we really wanted to discuss the importance of cancer screening for women, in particular Hispanic and Latino women. We know that cancer screening can help find cancers before signs or symptoms actually appear. But most people are a little confused sometimes about exactly what screenings they should have and when they should have them. So our main goal is really to talk about cancer screenings and why they're important and how they can reduce the number of individuals developing the disease if we can detect it early, and also, preferably to help their long-term impact by having had their cancer detected early. We all know that if we wait too long to be detected with cancer, our options may not be as helpful, and treatment options may not be as helpful as we would like. And so therefore, we really work hard to encourage people for screening. We know that Latinas have lower screening rates for many cancers than their peers in Texas or across the nation. And again, this can lead to later detection of cancer with worse outcomes. And so we truly want to make a difference here. And we're so excited about our panelists to share their own stories and also, about why it's important to get screened. Fortunately, today we have a wonderful panel of experts to discuss their challenges and to share on how we can improve and encourage cancer screening among our Hispanic and Latino population. So it's a great pleasure. I'm going to briefly introduce each of our panelists, and then our first speaker will be Dr. Chado. One of our cancer experts is Dr. Marcela Mazo-Canola. She's a specialist in hematology oncology at our NCI-designated Mays Cancer Center at UT Health San Antonio. Her research interests are in solid tumors and malignancies in the Latino population, as well as the different health disparities that affect our community. Dr. Mazo has certifications in American Board of Internal Medicine, Hematology, and Medical Oncology. We're also joined by Debbie Dinardi. She is a triple negative breast cancer survivor from Argentina. Debbie is an amazing patient advocate for genetic counseling and testing, and then also looking at the importance of healthcare access and cancer screening in Florida. So we're really glad that you were able to join us today. And she's also a volunteer and board member of FORCE, Facing Hereditary Cancer Empowerment. And our first speaker this afternoon represents our webinar sponsor, Genentech, a biotechnology company and a member of the Roche Group. Dr. Tania Chado is a principal oncology medical science director with the U.S. Medical Affairs, Scientific Collaboration and Alliances at Genentech. She started with Roche as a lab lead in preclinical toxicology in 2007, and then she joined the oncology leadership team in December of 2014. She later led a strategic development of a tumor agnostic biomarker-driven phase 2 study in the US in different community sites, and leads the One Oncology Partnership, in addition to recently joining Scientific Collaboration, where she supports several NCI studies in various cancers. So today we're just excited to have all of our 3 panelists, and we're going to have a conversation with them. But initially, I would like to have Dr. Chado, tell us a little bit about why is Genentech interested in making sure we have inclusivity of all our population groups represented in different studies and in cancer screening?
Thank you so much. I'm so excited to be here and to represent Genentech. And I'm going to keep it brief because the panelists have a lot more exciting things to say. But I really want to double down on the commitment that Genentech has in this space. So, firstly, thank you for the opportunity to be here. Like I said, I'll keep it brief because I don't want to take time away from the other panelists. But at Genentech, we recognize that engaging with the Hispanic Latinx community and building trust here is a key first step in addressing health disparities. I'll start by saying that Genentech not only talks the talk to be more inclusive, but we're walking the walk. And I'm so proud to be part of this company to really move the needle for all cancer patients. To this end, Genentech has a Chief Diversity Office, and through this, we sponsor the League of United Latin American Citizens and the Congressional Black Caucus Foundation, for example, both of whom are working to change policy for better access to diagnostics and medicines, all in that aim to make sure that everybody has access to our medicines and trials. We also have commitments across all of our molecule teams to plan early on how to improve Hispanic Latinx participation in our clinical trials, because our ultimate goal is we want to represent the patients that we ultimately serve with our innovative medicines. This includes bringing in more sites to our trials that reach these populations like MAIS. We also have corporate giving, which engages groups like Salud America, who's working in education on screenings like today's seminar. But in my remaining minutes, I just want to focus on this clinical trial participation, which is often coupled with other systemic factors such as higher unemployment rates or likelihood to be uninsured, which means that many Hispanic or Latinx communities are being left behind and do not have equal opportunities to access investigational medicines and contribute to medical and scientific progress. So in 2021, Genentech launched the Advancing Inclusive Research Site Alliance. And this coalition of clinical research sites partnered with Genentech to advance representation of diverse patient populations in all our clinical trials. And really, we're trying to establish best practices here that can be leveraged across the industry to achieve health equity for people with cancer. So each of these centers will focus on enabling historically underrepresented groups to participate in Genentech's cancer clinical trials and will work collaboratively and co-develop and share key learnings to explore innovative ways of increasing access and increasing education like we're doing in today's seminar. One of our founding sites, the Mays Cancer Center, is focusing on increasing the number of Hispanic Latinx patients in our trials and then developing information to improve the recruitment efforts nationwide. The Alliance also provides an opportunity to understand and build infrastructure really at the grassroots level so we can develop an ecosystem based on trust with committed leaders at centers who understand better the communities that we need to serve. I just want to give you a couple of examples before I hand it over of what this means for patients at Mays. This means they'll have things like access to transportation services or services in English and Spanish because we know they serve a large Spanish-speaking community. They also can work closely with their social workers to get informational and educational sessions like this in both English and Spanish, and so that we can inform our communities like we are today about the importance of screening. And then if something is detected, we can help them with the connection to get the treatment they need. We also have a global patient foundation that allows access to many of our medications. And we even have a farm worker program to gain understanding of the access barriers that Latinx farm worker communities in California and Oregon face, and to support access to free drug in some cases. So hopefully these highlight some examples of where Genentech is really working to ensure all patients have access to trials, medicines, and now in this forum, education for early screening efforts, all really in the aim to improve outcomes for all cancer patients. So thank you. I'm excited to be here, and I think I can pass over to the next speaker.
Yes, no, well, first of all, thank you so much, Dr. Chado, for expressing and the interest of Genentech in inclusivity, and it's so important. And, the topic of screening is important because we know that there's been delay in our Latino community for coming in for screening. And at the same time, as they come in for screening, we want to inform them about clinical trials. Should they need one, if something is detected, at a later stage and they're going to need a trial, or if, a family member might need a trial. So the importance of clinical trial education at an early stage and just informing our community is so important. So thank you for your words, and we'll involve you more in our discussion as we go along. Our next speaker is Dr. Canola. She has just been doing some amazing work here in San Antonio. And Dr. Canola, I wanted you to share, what have you, heard in terms of the myths and misconception of our Latina community of why they delay coming in for screenings, and what words of advice for the different types of screenings that we have available would you provide to our community?
Dr. Ramirez, thank you so much for the invitation. I'm very happy to be here. So yes, unfortunately, we still see a lot of myths, a lot of fears when it comes to breast cancer screening. I will say that a lot of times our patients are afraid of feeling pain. Although I will say that sometimes a mammogram can be a little bit uncomfortable. You can take a medication such as a Tylenol and ibuprofen to decrease the discomfort. But for the most part, the test is well tolerated for most of our patients. Other barriers that we have seen in the past is that patients cannot take time off. Their employers don't give them enough time to take off from work, or they're going to have to, not receive pay because they're taking time off from work to come and get screened. And I will say probably the biggest one is the fear. It's important to know that in our Latinos, Hispanic community, we're more likely to be diagnosed with advanced cancer when we compare to other ethnicities, such as the, white, non-Hispanic ethnicities. So these delays will cause the patients to be diagnosed at a much later stage with likely a more advanced breast cancer. So I always tell my patients, keep in mind that the earlier that the cancer is diagnosed, the better the prognosis is going to be. So if you're feeling something, you notice something in your breast, don't be afraid. It's best to go ahead and get that screening test done and find out what's the cause of the problem that you're experiencing.
Great. And what other tests should Hispanic women be interested in, such as, for detecting early cervical cancer?
So detecting cervical cancer, it's important. So go to see your gynecologist. There's some specific guidelines that we have nowadays. Now not everybody has to get pap smear every year compared to what we used to believe several years ago. There's ways to risk stratify a particular patient to determine how frequently they need the pap smear. And I will add also with the breast cancer screening, Dr. Ramirez, that it's important for the patients to know very well their family history, because if they were to have, a significant family history, for example, a first-degree relative that was diagnosed with breast cancer or ovarian cancer at a young age, or if they have a male in their family that was diagnosed with breast cancer, or if they have had bilateral breast cancer in their family, these patients need a different type of screening. They need to start earlier compared to the general population, and they need possibly to get genetic testing, which will affect the way that we screen them, for breast cancer compared to the general population.
And what ages should women come in for screening?
So that's a very good question that I get a lot. So we have different institutions in the US that have several recommendations for when to start breast cancer screening. As a rule of thumb, I tell my patients, you can go ahead and start by age 40, okay? General population, average risk, no family history or no genetic cancer in the family. You can start by age 40 and you can get your mammogram every year or every other year. My personal recommendation for my patients as a breast oncologist is you should get it done every year, okay? Up to age 75. If you reach age 75, but you're in good health and your life expectancy is measuring more than another 10, 15 years, you can continue your screening if you wish to do so. And I will add also that the screening that we do nowadays, we should do it with 3D mammography, since it's more, widely available in our country, and most of the, big institutions and even more rural institutions have access to a a 3D mammogram instead of what we used to know as 2D mammogram.
Great. No, this is just so important. And, you know, coming in, again, as you emphasized before, coming in early, starting early if you don't have any kind of history, but knowing that family history. And we're going to hear from Debbie, who's actually a breast cancer survivor, to share her story, you know, and before you get to cancer, you know, to really know about your risks. So Debbie, will you share your story with us?
Hello, and thank you so much for inviting me and allowing me to share my story, because I think it's really important for a lot of patients and Latinas too. So I was originally, I'm from Argentina. I was born in Buenos Aires. I grew up knowing that my mom and aunts were sick. Back then, they wouldn't say the word cancer, they were sick. My mom was diagnosed at the age of 39 and she passed away when she was 44. And 3 of her sisters also, between the ages of 40 and 45, they died of breast and ovarian cancer. So I grew up with a very small family. I was 13, my sister was 11, and really we knew that we had to do some screening, or more than usual. And my dad was the one just calling us all the time. It's like, did you do your screening? Did you go for your mammogram? So I started really early because I found some cysts and some fibroadenomas that they tested negatives at that point. They were benign, and they removed them, and I continued doing my screening. But back then, nobody offered to me any genetic testing. So I continued my life. When I was 35 years old, also, they found basal cell carcinoma here on my lip. Then because of bleeding, they recommended to do a colonoscopy that same year when I was 35 years old, and I had some polyps also in my intestine. So there were a lot of things going on in my body that it should have hinted my healthcare provider to tell me you should get tested for hereditary cancer, but nobody mentioned that. So I continue. And when I was 48 years old, I felt a lump. After 4 months of my mammogram, in December I had a mammogram. In April, I felt a lump in my left breast. And I went to my doctor, and he was looking at the December mammogram, like trying to find something there. There was nothing there. So it was fast growing. His face told me that this time it was not a benign tumor. And we did the biopsy, and it was a malignant carcinoma. So after that, I started talking with, he told me, well, let's do the lumpectomy. And he told me to go and talk with an oncologist. I went to the first one. They told me what treatment they would do. I got a second opinion, and they told me that too. Then a friend of mine said, I'm going to take you to my doctor because she is a fantastic oncologist. She's the first one that told me, because of my type of tumor, that it was triple negative breast cancer, and my family history, I should get tested. So my third oncologist told me, and I felt that really she was doing something for me as a patient, that it was personalized the treatment, that she was looking into my family history. So she told me, you should meet with a genetic counselor, where I developed my family tree. There they said, well, yes, you qualify because of your aunts and your mom and all your family history, you qualify for genetic testing. I did it, and it came back positive to the BRCA1 mutation. So the BRCA1 mutation is what runs in my family. So after that, based on all that information, they developed a plan for all the things that I had to do for this not to come back. So first it was chemotherapy, after that double mastectomy, and after that they recommended also a hysterectomy because of the chances of having ovarian cancer, that the report showed like 74% probability of having ovarian cancer in my lifespan. So that is what I did. When I finished that, my surgeon said, do you know about the organization Force? They provide support. They do this, they do that. They have peer navigation. They serve families. So I started just researching that. And I started talking with other patients that they were going through the same thing, because really you feel lonely. You feel like nobody's having the same journey just because you have a family history. And at the same time, my sister also tested positive. We were two, and both of us tested positive. So we're thinking about our families. What do we do next? So what I wanted to share a few learnings of this experience that really should be good for other patients. The first one is ask questions, research in trusted places, not everywhere in Google. Research and ask questions. The second one, if you need to go for a second or third opinion, that is not going to be something that, because some Latinas think that if they do that, that is disrespectful for their primary doctor. And I said, no, because it's your life. So you really need to get a second or third opinion. The third one is that if you feel something, as you mentioned, Dr. Canola, go and get it tested. Even if you're young, the first doctor dismisses you, just go and ask another doctor. Don't give up on your health because you felt something that is not normal. So just do it. Then the third one is that early detection saves lives. And that is something that really everybody needs to just remember that, because if you find it early enough, you will be able to have a good prognosis, as Dr. Canola said. If you find it late, that is really very difficult to face. So the next one, what I was saying, late diagnosis, really, it's a problem, because what I tell the patients is like, when you're diagnosed with advanced cancer or stage 4 cancer, it means that you will live the rest of your life with cancer and treatment, because today, metastatic cancer does not have a cure. And that is the message that I always give the patients, that they're referred to me via support groups. Another one is, if you have family history, go talk with your genetic counselor, get an evaluation, get tested, and even if it comes back that you don't have a mutation, you cannot relax. Because some people say, I don't have a mutation. I said, it doesn't matter, because you have family history. So if you have a large family history of cancer, you should continue with the regular screenings, because maybe they have not found the mutation that runs in your family. So it's really, if you have family history, get screened, just more frequent screenings. Also, when you're diagnosed with a genetic mutation, in 2008, Congress passed a law that you cannot be discriminated. It's called GINA, and that is for Genetic Information and Non-Discrimination Act, that only applies for health insurance coverage and employment. If you need to have, for example, life insurance, you should evaluate that before getting genetic testing, because most of the insurance companies, after you are diagnosed with a hereditary cancer, they are not going to cover you for life insurance. And the last one is that you don't have to do this alone. Really, this is extremely important, that you find a support group, that you find other patients and other families that they have gone through all this process, and you will be able to just help somebody else.
Great.
You have
Thank
a
you so
question,
much.
Marcela?
Yes, Dr. Canola.
I just wanted to add a couple comments to what Debbie said that I think she made, it's very important. So you mentioned that you had a mammogram 4 months before you felt the lump. So it's very important that our patients know that there are some aggressive forms of breast cancer that will grow in between your year, the yearly mammogram that you just had. So if you feel something, you got to get it checked. Keep in mind that about 20% of cancers can be missed by mammography, although it's still our best strategy to screen patients. Some can be missed. So it's very important to know our bodies, to know how we look, to know how things feel normally. So we're going to be more sensitive to identify very subtle changes. And the other thing that I wanted to add to your comment, Debbie, is genetic testing has come a long way. And there is, very good programs to make it available for our patients, even if they want to know their lifetime risk, that basically there are some affordable options. Sometimes insurance companies will have they won't cover a lot of this testing. Most do, but some don't. But just know that in big cancer institutions such as ours, we have programs that will allow you to kind of knock on the genetic counselor's door and say, okay, I feel like I need to do this because something is in my family history and I've never been tested. Even if you're uninsured, there is ways that you can, access to these services and talk to these people to, to still access the test that you need.
Thank you so much for adding that, Dr. Canola. And we just recently had that conversation, where a woman told us I had gone in for a mammogram screen, everything was fine. But then a few months later, she felt a lump and was really just like Debbie said, her doctor was surprised that they hadn't, seen anything there before. So women know their bodies better than anyone else. So, please, if you feel something different, be sure and see a doctor as soon as possible. I wanted to ask Dr. Chado, as Debbie mentioned, and so did Dr. Canola, that the mammogram is a great test and it's the best tool we have right now. Do you know if there's anything in the future that's going to have a better testing for breast or other types of cancer? Because in the Latino community, I'm often told when I'm doing focus groups, I don't want to have that tortilla press, placed on me. And I said, and men don't have to put their parts in something like that. So when are we going to have something that's more sensitive for women?
I wish I knew the answer to that question right now. And I think Dr. Canola will agree with me. Mammogram is still the queen and will probably remain so for a long time. However, the early cancer screening tests, some blood-based biopsy tests, all of these things are of very keen scientific interest. So we are moving as fast as we can on the science front. But right now, today, I can say this as a woman and not an employee of Genentech. I know mammograms are uncomfortable, but I go all the time religiously because early detection, early detection, early detection. We catch it early, we can treat you, you can have a normal life. If we wait, if it comes too late, that's where things get tricky. So mammogram is queen, right? Dr. Canola, I think.
I will have to agree with that, honestly. Yes, and then there's newer technologies coming our way. There's actually different types of mammographies that are under study, that is contrast enhanced mammography, for example, in which, they put a certain dye like they do when you do an MRI, for example. There are certain technologies that I hope that, they become available to us, but to this day, to 2022, mammogram is still the way to go. Yes, it's not a comfortable test, but it's better to be uncomfortable for a few minutes than to be, in a difficult situation for the rest of your life. And there is no question that us Latinos, we are more prone to be diagnosed at a young age when it comes to breast cancer. And we are more likely to be diagnosed with advanced cancers and more aggressive histologies. So yes, we all need to go and get that mammogram, as uncomfortable as it is.
Thank you. And I wanted to ask Debbie, you talked about that you really didn't know what your mother and aunt had passed away from. And we hear a lot of that, because in the Latino community, families are afraid that if they talk about cancer, they're really passing it on. So can you share with us your views on that, or what other things, what helped you identify your family history? And you're muted, so you can unmute.
I'm okay now. Can you hear me?
Yes.
Okay. Really, it was all the time in the back of my head, because just growing up with such a large family history that I knew that at some point in my life it was going to happen, but nobody mentioned that there was a genetic test, that it could at least give me options before. Because one thing is when you're diagnosed and then they give you the genetic testing results, it's like, I wish I would have known that before, because now we have so many, as we call them, previvors, that they are those patients that they are able to receive the results of a genetic test. And with that, they can make decisions to prevent them developing cancer, for example, having a double mastectomy, a hysterectomy, or sometimes now they mention that by removing the fallopian tubes, also you can reduce your risk of ovarian cancer. So there are many options now that by knowing your family history and your genetic predisposition, the doctor that can help you to make a plan, depending on your age, on what to do in order to be able to be, I'm not saying cancer-free, but just prevent some of those cancers from happening to you. So really, I think that now we advance a lot, and that information is critical for our healthcare decisions. And that's why we try to share with all our family members. And that's why now I'm trying to participate in clinical trials and find out a little more, because the more we know about this, I will be able to offer these solutions to my kids because, for example, they haven't been tested yet. And really, for me, it's such a burden that I have to tell them, maybe you carry the mutation, maybe you may pass it to your kids too. So really, I'm doing as much as I can, sharing my story, just participating in clinical trials, working with different organizations, just to advance as much as possible to be able to provide a solution for future generations.
Can you share with us the type of trial you participated in?
Well, there's studies more than trials. Now I'm going to start participating in a clinical trial because usually it's when it's prevention that I didn't have the opportunity to do that. So right now I'm participating in a couple that what we are trying to find out whether or not genetic testing is being offered to Latinas when they are diagnosed with cancer. And not everybody, so it's a pilot study that we started. We are doing all the interviews and everything in Spanish. We develop all the questionnaires in Spanish. We are reaching to the Latino community here in South Florida and through genetic counselors also in the US, just to make sure that whether or not they are being offered. And sometimes the answer is like, no, I was not offered. And why? It's because you may not understand what to do. Sometimes they don't explain it very well to Latinas because they think that they will not be able to understand. And they may say, no, I don't want to do it. So really, we're trying to understand if it's being offered, and if not, why, what was the reason? So then in the future, we can educate genetic counselors and other caregivers also and doctors, just to make sure that they can offer that option to Latinas. Because if we educate them, they will say, yes, they want to know their genetic predisposition.
Yeah, and Dr. Canola.
So adding to Debbie's point, yes, mutations will increase your lifetime risk. But as you mentioned it, if you do have a significant family history, even if your test is negative, we can still calculate your lifetime risk of having breast cancer or ovarian cancer based on your pedigree, meaning your family history. And if using certain models that we have, if we know that your risk is close to 20% or more than 20%, you can access enhanced screening when it comes to breast cancer. And that includes, medications that will decrease the risk, such as tamoxifen, which is a medication that we commonly use after the patient has been diagnosed with breast cancer. And we can also offer enhanced screening, meaning alternating mammography with magnetic resonance of both breasts. So those strategies are there, they're available. So it's very important, to talk to your doctor. And also mentioning as far as the genetic testing goes, I remember that I have this young woman that, she told me she is 41 years old, and she was looking at me and she had a BRCA1, and she told me, what's the point? I'm going to get cancer anyways. She was telling me, that, and, she had a valid point, but there is different strategies that we can discuss with each individual case to decrease their particular risk. As I always say, information is power. If we know what you have, we are going to be more successful by developing a strategy for you that won't make your risk zero, but it will decrease it to a degree that, that we, help you live a very, healthy and long life, cancer-free.
Thank you so much. That's so important to recognize and to have that faith and confianza that there is these alternatives out there that can truly help us. And also, can you share, Dr. Canola, about breast cancer survivors? Sometimes they've reached their 5-year mark and they think, okay, I'm cancer-free now. Is there any special words for them that you'd like to share?
And that's a very, important question that you ask. And I will say, by definition, we call a survivor anyone that has been diagnosed with breast cancer and they have, they're past their diagnosis for 5 years. However, I will say, and this is kind of my personal take on it, depending on your risk, the strategy that we develop for you, as far as for how many years to follow you, might be, different than for maybe someone that that had, breast cancer. As a rule of thumb, if you have what we call hormone receptor positive breast cancer, meaning that the cancer was using hormones, I tend to watch them a little bit longer because we can see some late recurrence even after, 10 years. So I might keep those patients for a longer period of time. Patients that have triple negative breast cancer, usually if they're going to recur, they tend to recur a little bit early. So usually after 5 years, we graduate them. And there is another specific type of breast cancer that we call HER2 positive. Usually that specific cancer will have kind of earlier recurrences if they're going to happen. So usually those patients get graduated, I call it like that, after 5 years. Being that said, getting yourself enrolled in a survivorship program, meaning, a specific type of provider, mid-level physician that will be familiarized with the kind of, side effects that you're going to be dealing after you underwent certain treatments, side effects from the radiation that you went through, psychological side effects. It's important to, if at all possible, to participate in those kinds of programs, because these people are going to be trained to know what to look for. They're going to teach you, what symptoms to be kind of on high alert in case that a recurrence may happen. And ultimately, they will help you into that transition, into that kind of normal life after you have been treated with a breast cancer.
Great. Yes, we have a new study that we've introduced at the Mays, really funded through the Susan G. Komen Foundation, to help us look at a combination of exercise, yoga, and spirituality for our breast cancer survivors. And, and to help them also deal with stress, because that concern that cancer may come back is always there. And so we really are working on all of those elements to continue to help them as much as possible. And then we're doing another study with the University of Miami in terms of recruiting in South Texas, 1,500 Latinos and 1,500 from the Miami area in terms of cancer survivors in general, all cancers. But we really want to look at specific issues dealing with quality of life. So I wanted to mention something that Debbie brought up in terms of educating about clinical trials, and go to Dr. Chado. We're so excited about being part of the AIR Alliance project, in which we're educating not only our patients, but also our physicians, because we know that some physicians carry implicit biases, and that sometimes, as Debbie mentioned, that maybe a trial is not offered because they pre-conclude that maybe they won't get here for all the visits that we need, or there's transportation issues and so forth. Can you expand a little bit more on that project?
Sure, I'd be happy to. And this is something we're very, very excited about as part of Genentech, to bring in these new sites and find out what the problems are and work with you guys on also, finding solutions like transportation. This should be a no-brainer. If you want to get on one of our clinical studies, this is something that we should and will cover. But as part of this advancing inclusive research, this cross-functional US initiative, there's 3 main priorities. The first I've mentioned a lot about. This is the clinical development strategies to recruit more patients that are representative of the US population. And so we're doing this as a first-in-class network of clinical trial sites in underserved communities. And this is where Mays is a part of this already. A second tenet of that is personalized healthcare. So we want to enhance personalized healthcare. As that says, personalized, it's all about the person. That's not only the medicine, which of course will be tailored to your personal cancer, but that's also what you need as a person. Those things, the transportation, the mental, how much time are you going to have to take off of work? Things like that. We want to try to look at the gaps and find solutions together to ensure that we can get an accurate diagnosis and optimize treatment outcomes for all patients. And that can include a clinical trial. And then the third one are these external partnerships. So we want to build external coalitions and partnerships in the Black and Hispanic Latinx communities and really work together to build that trust with these patient communities through symposium like this, through working in these partnerships to really collaborate among the whole industry to do better. And again, get access for all patients across this country to our medicines and trials. I hope that answered the question. I see Debbie there.
Thank you. As you can tell, it's multi-complex, right? It's not just a simple solution, and it does take many partners. Together. Yeah, many partners working together. Debbie, you wanted to add something.
Yes, I wanted to add that really is very important for our community is to educate our patients, because usually they think that a clinical trial is like you're going to be a guinea pig. And they have that preconception from the past that that is the way that it used to be. But when I talk with patients, I said that would be unethical to put a cancer patient through a clinical trial and give you a placebo. So the two groups that you're going to have, I always explain to them, one is going to be the standard of care, that is the medication that is being used today, and the other group is going to be offered the new medication, and they are going to conclude whether or not the new medication is better and the side effects and this and that. So I go through all that explanation. And also what I tell them, why it's important for Latinas to participate is because right now there's statistics that all the clinical trials, they have 70% white, 2.5% Black, and 2.3% Latinas. So what does it mean? Is that those are figures from the AACR that they just published this report. And really it's so important because we are not participating. We are not, by not participating, we don't know if that medicine is going to be effective on our community, if that medicine is going to have other side effects that they are not reported by other communities. So that is what I always try to emphasize about clinical trials when I try to recruit patients. I wanted to add that.
Right. No, thank you so much, Debbie. Very important. Dr. Canola.
So speaking of personalized medicine, I just want to, kind of tell everybody in the webinar that your participation makes a difference. It matters. Latinos are the fastest growing minority in the US, and biologically, we are different. And that means that, as Debbie pointed out, that the response might be different, that the side effect profile might be different, that certain things might be need to treat it differently. So in order for all of us to be successful as a community, to get really our Hispanic patients that we know are going to be diagnosed with breast cancer, just, this year alone, we're calculating about 180,000 cases of new cancer in the US and just Latinos. That's a lot of people. So really your participation and you being part of this effort, it makes a difference. And adding to your point, Debbie, clinical trials are highly regulated nowadays. I know that there's a lot of mistrust from the past, but they're very regulated. I sometimes tell my patients, I feel like when you're in a clinical trial, you even have more layers of care in between you at home and your doctor, because you have the research team checking on you, you have the research nurse checking on you. So it even adds an extra layer of care that I quite frankly think it helps our patients feel better. And, I keep that stressing of how important it is that our patients, participate, that they help us out. It's a community effort. And the only reason why we have made so much progress, because I'm so proud to see the progress that we have made in the past few years as far as, breast cancer, across all cancers, is because someone 5 years ago, 10 years ago, agree to participate. That's the only way that we move forward.
No, and it's, I just wanted to point out that breast cancer is the leading cause of cancer deaths in Latinas. Yes. And that, combined, our Hispanic Latino population represents almost 19% of the US population. So as Debbie said, that small percentage of our representation in clinical trials is very, very small. And then going back to you, Dr. Canola, the heterogeneity of our community, ranging from European to African American to Native American, it's just the wide diversity of all the population groups that we represent within our ethnicity is truly important, that we try to be as inclusive as possible. So all of those points are extremely important. We had a question from the audience, and I'm going to open it up to whichever panelist would like to respond. But one of our audience members works with a large Latina immigrant population, and that they find that their male partners will sometimes discourage them from going into having the mammography screening because they don't want their spouse to be seen by others. And also that women sometimes don't want to come in because they feel that they might not be able to afford the treatment should they get diagnosed. So would anybody like to comment about that?
If I may, I will say that one of the strategies that we have used at the cancer center is telling the patients that they can get a female technician doing their mammogram. Most of our technicians are females, and the nursing staff, we can request a female nurse to escort that patient, and that should, I hope, mitigate maybe that fear of being seen by somebody else. The mammogram process itself is very private. You're by yourself in a room, with a female technician for the majority of cases. So there's ways to hopefully mitigate that fear of being seen by somebody else. As far as being able to afford the treatment, this breaks my heart because I see it all the time, unfortunately. There are different options to help our patients as far as, grants, applying for different sources of support to help them with the treatment. But I will say we still have a long way to go, as far as, getting patients to know that, for example, in the state of Texas, they can get extended Medicare to, help them with the payment of bills and such. But it's best to go and get checked. The longer you wait on this problem, the bigger and the worse that it's going to get. I feel like, and I tell this to my patients, there's always a way that we find something to help you. I've had patients that for whatever reason, they couldn't qualify for X, Y, or Z insurance or county program, especially here in San Antonio, we have one called CareLink, but we have been able to get them, different grants to help them with the treatment. And to this day, I have patients that are getting treatment based on a grant that helps with, with all the cost. So there's always a way. We still have a long way to go, but we do have resources to help you and to, get you through treatment.
Great. And Dr. Chado, do you want to mention anything that maybe Genentech might have or could help?
Yeah, we sponsor and have multiple foundations, particularly for some of our medicines for patients that can't afford it. We have a line you can call to get help in that regard. I would echo, the sentiments of Dr. Canola. We have a long way to go in terms of, medical in the U.S., healthcare system that, Genentech can't solve, obviously. But I would say there are lots of grants and other things out there that patients should access all the way through as far as they can, and that it is worth it up front than on the back end, as was said as well. So
great. Thank you. Thank you. Dr. Canola, in terms of educating our future physicians, any words of advice to them, and in terms of really promoting screening in a population that might not ask for it or that has misconceptions about the importance of prevention?
Education is the way to go when it comes to everything. And we really still have a long way to go as far as, educating ourselves as physicians and educating yourselves, our communities. So of course, we have a responsibility being physicians in training to be, up to date with the most, set of guidelines to know what to tell our patients. Communication is key. And to the patients, I will also say that if you feel like something is not normal, if something is off, doesn't feel right, be persistent, talk to your physician. As Debbie mentioned, maybe get a different opinion. Because physicians are humans. They're gonna make mistakes. I mean, to err is human. So if you feel like something is off, be persistent, know your body. And for the future generations, me being, an assistant professor at the university, I feel like caring for these issues is what's gonna make you do a good job. If you care, you're gonna do a good job because you are invested in the cause. So make sure that you know what you need to tell your patient. And always, of course, I mean, us that are in the trenches of oncology, we're always available if any questions, if any concerns, or if you don't know what to do.
Thank you. Beautifully said. Thank you so much. And one of our audience members mentioned the issue of language as a huge barrier. Would anybody like to mention or add to that?
I'll make a comment then. So we recently, and I'm going to share this because I'm very proud of this. We recently celebrated the first Latino Physician Day in the US. So of course, language barrier is a big disparity. I feel like we're making progress as far as being able to communicate with our patients in the same language. And I'm proud to say that my cancer center offers, for example, most of the clinical trials are, given to my patients and they consent in their own language, which most of the time is Spanish. So yes, it's a barrier, but I feel like the way to overcome that barrier is recruiting more diversity into the, into the healthcare arena, getting more doctors to, to go and participate, getting more of those Latinx students that are, not deciding what to do with their lives. You're needed in healthcare. So it's 19% of the US population, 6% of physicians are Hispanic, and 2% are oncologists. So we need all the help we can get.
Right. It's so true. So true. And Debbie, yes.
Yes, what I try to always do is with all the organizations that I volunteer here in Florida with FORCE, is just to make a portal in Spanish, to translate the brochures, to make sure that all the information is also accessible in Spanish, because that is a way to share that information with the community. When I go to a mammogram event, for example, I take all my brochures, and I'm so happy to have some brochures in Spanish, because really that is going to make a difference. So that is what I do from my point of view, is just to help to have enough information for them to be educated and to make the right decisions for their care.
And I just also want to say, from the informed consent side, we're doing a lot of work there to make sure that we translate into all the relevant languages when it makes sense. So we know it's a barrier. I think, as you've heard, we're trying to move the needle on that one and make it available in as many languages as possible.
Great. No, thank you. And it's just so important, even though, our population's transitioning, they may be speaking more English, but when it comes to a critical issue as being told you have cancer or a health issue that you're struggling with, hearing it in Spanish or reading about it in Spanish kind of helps reinforce some of the information that you need to help you get through it. So thank you all very much. We're coming to minutes left here in our session today, and I'd like to go around each of you and just maybe some closing remarks that you'd like to say. And I'll start off with Debbie. I wanted to ask Debbie, how would you go about telling your abuelas or tus hermanas or close family members that they need to be screened, and that if there's any concerns, that there's a family history, that they should ask about genetic testing?
Yeah, the first thing that I would just try to break all those myths that cancer is a synonym to death sentence, that now if you're screened on a timely basis, cancer is treatable like many other diseases. So that is the first thing. And also it's like, really, the more information they have, the better prognosis, as Dr. Canola said, that they will have. So that is really very important. And also, one thing that I just wrote myself some notes here, that I try to share stories about other patients. So in that way, when I talk with my family, I said, oh, I know this patient that did this and that. So really, when they can relate to other patients, that is really a powerful story for them to also make the right decision.
Thank you so much. Dr. Canola, any last thoughts?
Do not procrastinate on getting your mammogram.
Okay, great.
Get it done.
Dr. Chado?
Ditto, ditto, ditto. And remember, clinical trials are a viable option. Should you have cancer and you've exhausted standard of care, please consider clinical trials, and we're here to help.
Great. Thank you so much. Well, I want to thank all of you for your time. You know, it's so important to hear from our physicians, our survivors, our advocates who are working to improve not only access to screening, but as Dr. Chado said, you know, educating about the importance of clinical trials, and it's truly making a difference. And, you know, we've done a number of studies to try to say, when is the best time to educate our community about clinical trials? We want you to know about it, because if you go and are offered one, you at least have some knowledge about what it can do for you. So it's truly important that you get this information as early as possible. And you know, we'll be adding this link to a YouTube link so that people can have access to this. If you want to share our discussion today, we really encourage you to do that. And again, we want to give special thanks to our sponsor, Genentech, for having us, allowed us to do these 6 series of webinars, and we continue to make them available. And we're so glad to be part of AIR Alliance, and as well as also through the foundation work that we're doing to educate communities about clinical trials. So thank you all very much for your time. Thank you to those who were with us today, and we look forward to seeing you again soon. Thank you. Have a great day.
Thank you.
Thank you.
Bye.
Thank you. Bye.